Um, so I just want to obviously bring you here today to talk about why Frailty Matters. So I work as part of the Home PCN and Frailty Service, and this is obviously we're rolling out Frailty home visits. And part of the work is what we identified was really we need to know more about frailty across the PCN as part of the service. So today I'm going to just go through and present why frailty matters and looking at some of the concepts around frailty and some of the methods of how we help improve frail patients living within our community. So today's training objectives is what is frailty and how can we recognise acute frailty syndromes to assess for frailty, to understand the importance of communication and person-centred care, and be aware of the evidence-based strategies around frailty in relation to sort of prevention and management plans. So what does frailty mean to you? Well, obviously it's hard for me to communicate with you, but normally when I've done this in the room, people have sort of come up with various suggestions. But after many years of research and evidence, the sort of leading definition, which has come out from NHS England by John Young, is that frailty is around the process of our bodies gradually losing their inbuilt reserves. This leaves us very vulnerable to dramatic and sudden changes in health and triggered by seemingly small events such as a minor infection or a change of medication or environment. And we see that regularly with our patients in terms of seemingly minor infections like a urinary tract infection can lead to a significant decline in health status. So going on from this, frailty is a presentation rather than defined around age. And it's an effective way of identifying people who may be at greater risk of future hospitalisation, care home admission or death. So, for example, people living with severe frailty have over 4 times greater annual risk of those outcomes. So this is a significant health problem that needs to have a significant strategy to manage and promote best outcomes for patients. So going on to think about, well, why worry about frailty? So Age UK have done lots of statistical data and the prevalence. Around 3% of the population aged 65 and over in England live with severe frailty and 12% with moderate and 35% with mild frailty. So they're vast figures. Frailty occurs frequently more in women than men, which are about 16% versus 12%. But it's also not an inevitable part of ageing, and that's the key message to remember. Not all older adults will inevitably become frailer, which will become clearer as the presentation goes on. And frailty should be identified with a view of improving outcomes and not causing and trying to avoid unnecessary harm. So frailty state for an individual is not static, it could be made better and worse, and we are very much seeing this now that we're starting to introduce our home frailty visiting service, that we've seen patients that have been coded as severely frail, likely after an acute admission or event, and have had a significant decline, but actually 3 or 4 months later we're seeing that those frailty syndrome, the frailty index, has actually improved and they may be gone back to a mild and moderate. So it's not static and it can go up and down. So I think as an individual, just the knowledge that patients that they have frailty can help professionals to take actions to prevent poor outcomes. So this is all trying to prevent worsening outcomes for patients who are living with frailty. So when we're talking about frailty, there's 5 areas that we think in terms of acute frailty syndromes. And when we're assessing, these are things when patients are coming into contact with us, we could think they possibly have a frailty diagnosis. So if patients have fallen, if they've collapsed, their legs have given away, they've found on the floor, which again is a lot of the terminology we see and we use in hospitals. If they become immobile, if there's sudden change of mobility, again, hospital sort of documentation speak is sort of off legs, they were stuck on the toilet. Now, delirium is a significant area within itself. And acute confusion, sudden worsening of confusion in someone with maybe a diagnosis of dementia or no memory loss. Often we see patients who are presented with, again, a fairly innocuous infection end up getting quite an acute delirium, which presents with all sorts of different problems. The patient often may become incontinent, so they're having change of incontinence or new or worsening onsets. And this susceptibility to side effects and medication, I see Kevin's on the call, so he'll be very much aware of this, where patients are getting quite significant side effects from, again, fairly sort of routine medication. An essential feature to physical frailty is this loss of skeletal muscle, so what's referred as sarcopenia. So that's really important. We recognise those frailty syndromes. When we come across our patients who are presenting like this is the time to think, have they got frailty? Are they frail? So this compendium looks at how frailty presents. So often we see patients that have presented with some weight loss, and that leads to this muscle loss, which is the sarcopenia, which means that maybe a frail person has less energy and they're more exhausted, they're more tired, they sleep longer in the day, they nap. Then this kind of comes around to this decrease of strength, which then impairs the balance and leads to falls and injuries and immobilization, which can lead to disability and dependency, but also can lead to decreased walking speed, reduced activity, and overall, again, then it just totals of this total energy expenditure is less, and their resting metabolic rate is less. Then they just don't eat very well, so they have chronic undernutrition and inadequate protein and energy intake. So again, then they present with this weight loss, and it's just this compendium that just keeps this cycle that keeps going around. So thinking about how we diagnose frailty, there is some leading tools that are used. The British Geriatric Society are the leaders on frail care within the UK, and recommend that an outpatient or community setting is often the most appropriate way to diagnose frailty. So there's three leading models. One is around gait speed. So does it take the person more than 5 seconds to walk 4 meters using usual walking aids? Or the time up and go test, which is a cut-off score of 10 seconds to get up from a chair, walk 3 meters and turn around and sit down. And then the Prisma 7, which is a self-completed assessment on the person's usual health and functional status. So that's very much around the individual completing that, buying into sort of this longer term diagnosis. So there's two leading frailty models. The first one is the frailty phenotype, which was conducted by Freed and his colleagues in the States, which was validated as part of a cardiovascular health study and looked at areas that were prevalent around patients that were sort of more frail and prone to admissions. And then the leading one in the UK is the Frailty Index, which was Rockwood and his colleagues. It's based on a Canadian study, a very longitude study, which represented the most operational definition of frailty in the older person. Now, his study was actually based on managing older people who were living with dementia. But what came out was very sort of correlated information that could be used with older, frailer adults. So the models have a slight different method to how they look for signs and symptoms of frailty. So phenotype is very much based on sort of signs and symptoms, where the frailty index is more around activities of daily living, disease processes. They very much, the models, both of them very much look at sort of comprehensive clinical assessment, and they see different variables in frailty. But I think the leading model in terms of this country, the Rockwood, the clinical frailty score or scale, has been the more transferable into clinical practice, and that's the one that most units are using and adopting. So once we've identified people living with frailty by the Rockwood Clinical Frailty Scale, it's widely, so this is widely used in primary secondary care setting to grade severity of frailty. The frailty should be identified with a view to improving outcomes and avoiding unnecessary harm. So we always say that a clinical frailty scale should only be used in conjunction with a comprehensive assessment of the patient, and it needs to have about reviewing their medical, physical, social and psychological well-being. So we often see the frailty index is just used as a marginal tick box tool, and that's not what it was ever designed to be. It was designed to be used in conjunction with a comprehensive assessment. So the benefits around the CSF, and I think that's why it's widely adopted, is that you can identify degree of frailty, and it can be helped to summarise and communicate between healthcare professionals. And therefore, awareness of this measure is important to ensure effectiveness in practice. So thinking about Rockwood and his colleagues' scale, as you can see, it's a picture diagram. It's very easy and straightforward to use. It rates a person's clinical frailty score from 1 being very fit to 9 being terminally ill. And within our service, within our frailty home service, we are currently looking at the severe frail patients. So these people are completely dependent on personal care for whatever reason, whether that be a physical or a cognitive reason. However, they don't seem to be at risk of dying within the next 6 months. Within our care homes, we're seeing patients that are really moderatingly from 5 to obviously the sort of 9 category. So as you can see, it's got a nice easy picture chart available to it, and so it's very easy to just kind of look at your patient and think, okay, they look like that. The difficult and challenging aspect of using this score and scaling system is that it's quite subjective, and often people are coding and scoring maybe inappropriately or not really understanding what the sort of clinical pictorial relates to. So 5 is really where we're kind of basing a lot of our work around. The mild frail patients, so they have more evidence of slowing down. They're struggling maybe to keep order of higher independent activities of living, such as finance, transportation, heavy housework, medication, but generally can still manage sort of meal preparation and housework, and you know, they're still managing pretty well. Whereas the moderately frail patients are dipping into that area where they need more help with all activities outside and keeping house. They might have some problems with the stairs. They might need some help with bathing, some minimal assistance and queuing. And then we go on to the severely frail patients. Like I said, they're completely dependent on personal care for whatever reason. And then the very severe patients, they're typically approaching end of life and they might not recover. And then the terminally ill patients, which are within the next 6 months, their life expectancy is only up to about 6 months. So it's a really usable score, and it's very transferable into lots of different clinical areas. So when we think of frailty, we think of it in line with clinical uncertainty, and there's been sort of more and more research around frail patients very much sit within this clinical uncertainty. And we see the patients move up and down that frailty spectrum from vulnerable to very severe. However, patients with moderate to severe frailty are vulnerable to points of marked decline. So again, for example, patients that maybe have had urine infections or chest infections, we see marked decline after they've recovered, and they sometimes never do recover. So clinical uncertainty, which fits very nicely with frailty, is where we perceive an illness as an inconsistent or complex or unpredictable. And this can relate to treatments and recovery and prognosis. And we very much see this with our care home patients who have changed very quickly, and their medical conditions and frailty is just very inconsistent and complex, and it's quite unpredictable. So it's something to consider. So going on, we need to think about those patients living with severe frailty really need to have their goals optimised and maintain their function. All the evidence suggests and points to increased better outcomes when we really optimise patients' goals. So it's also really engaging patients and families to have that awareness of increased risk of decline and adverse outcomes, such as unplanned hospital admissions. And obviously that's something, you know, we need to try and avoid where we can. We know that frailty increases sensitivity to the effects of medication, which again can lead to falls and confusion. And patients should be offered a respect conversation, which is also involves talking to the person and the family regarding what their personal wishes around for future care needs and likelihood of moving towards end of life. So as healthcare professionals and the model within the care home and frailty team, one of our objectives is to ensure that patients are offered appropriate respect conversations so that we can understand what their wishes are in the event of a change in health condition. So going on about clinical uncertainty, Clegg et al. In 2013 did a very good research study that looked at frailty in elderly people, which was published in The Lancet. And it very much kind of came up with this, again, this quite visual picture of what happens when the frailer a person is, the more dependent, the bigger the impact of a minor illness is to have on mobility, function, and their ability to manage at home, really. So as you can see, an independent person on the green line has a minor illness, very much steps down for a short period and then back up to where their baseline is. But what we see with the more dependent, frailer person is that they have a very large step down with a slow decline, a slow inclination back up, but you can see they never quite get back up to that previous baseline. And we very much see that with our frailer adults, is that they have this stepped down decline until they get to the point where, unfortunately, recovery doesn't happen. And we also know that recovery for a more frailer person is much more longer. So that's obviously significant for us to understand that as healthcare professionals and also care homes who are providing the care. So acute frailty syndromes, as talked about, leads to increased risk of falls, increased risk of hospitalisation, which we know that older people, when they hit hospital, end up having longer lengths of stays, a much higher risk of readmission within 28 days. They have increased dependency with activity of living, and they're likely to require some form of care to help manage frailty syndromes. And we know that the trajectory towards institutional care is more prevalent for the frail person, with this increased risk of general decline and death. So the important message to remember is frailty is not an inevitable part of ageing. It's a long-term condition, such as that of diabetes or Alzheimer's disease, and needs to be managed accordingly nationally. So can we improve outcomes for people living with frailty? Yes, we can. So the main evidence points towards these particular areas. So there's lots of good evidence around improving physical function, treating reversible medical conditions, improving nutrition and hydration, and improving psychological status, and reviewing medications. Evidence suggests, and part of our locally commissioned service, patients require a person-centred care plan and goal, which should include end-of-life planning if appropriate, and that we need to incorporate community and outpatient services for ongoing support and management. We know that patients often do better in their own homes. Obviously, we are looking after patients who are in both care home and their home setting. So the main message is the 6 M's. So evidence shows us if we can manage these 6 M's, then patients will have better outcomes. So if we can improve mobility, if we can manage cognition, if we can address any multi-complexity, if we can manage medications, ensure malnutrition is addressed, and also to consider what matters to the person. So the first M, so evidence suggests that taking an integrated multi-component approach to address common risk factors may reduce frailty as well as length of stays. And generally our service around enhancing healthcare access to care homes, care home residents and patients who are living at home with frailty really is kind of what our service is trying to be based off. So the management options for this group of patients is vast. So we're going to look at the 6 M's, and all treatments need to be individualised to the person's needs, because obviously no one size fits all in this situation. So thinking about mobility, we need to ensure patients are moving, they're exercising in trying to prevent and reverse frailty and deconditioning. And deconditioning is, you know, such a significant problem to the frailer person. So it doesn't need to be massive weightlifting, it doesn't need to be hardcore exercise, but it just needs to be regular. So as much as walking, sitting, standing, as well as sort of thinking about any therapy specific outcomes. So there's lots of good evidence around strength and balance exercising, especially for those patients who may be more prone to falling. There's some great resistant work in terms of using of therabands and weights, because we know that can strengthen bones and muscles. And if we can strengthen bones and muscles, we're generally going to be able to strengthen, help with balance and movement and reducing risk of falls. So it needs to be tailored to the individual, what they can do. It needs to involve some standing as well, and it needs to be sufficiently progressive. So there's lots of resources online in terms of trying to support exercises. And this is just a dementia-friendly exercise for strength and flexibility. Again, there's lots of different methods online, so they can be utilised for our patients. And again, it's for our care homes, which this training has been spread out to the care homes. This is something that really the care homes definitely could be doing and being more proactive with their patients in terms of exercising and increasing sort of activity throughout the day. So thinking minds, early recognition and management of delirium or cognitive decline is really, really important. So again, thinking about how the care homes manage patients to encourage individualised socialisation and cognitive activities, to consider onward cognitive assessments and appropriate onward referral to memory assessment. And we also need to just not think about, when we're thinking about cognition, we need to think about mood as well. We know that people who have significant cognitive problems often have altered state of mood as well. So we need to be addressing that as healthcare professionals. Again, this is really more for the care homes and community services, is really utilising the tools out there. So the CHIRT team, so the care home inreach team, and SOAMs as well for sort of older adult mental health team. They're a really great resource that we've got in this area. So they are really fantastic at supporting care homes who are trying to look at better effective ways of managing patients with cognitive decline, and just those community services. So we know these patients are complex and have multiple complexity. Patients with frailty often have multiple long-term conditions which need a holistic management with prevention strategies in place. And we need to be aware of vulnerability to sudden change, because that's thinking about complexity. We know that our patients have these very sudden changes in their condition. So it's about trying to manage those changes and for us to be aware of them as well. Thinking about respect conversations and clinical frailty score and the likelihood of clinical uncertainty. So how appropriate is a respect conversation and a respect document? Just as a kind of aside, Chris Penhill, who is part of Sussex Foundation, is doing respect training, and Aisha has linked them into the care homes team for them to take more responsibility. So that's on the sort of the next agenda, really. And then thinking about other stuff like how do they manage continence? What's the impact on their quality of life? Thinking about catheters and not in certain catheters unless clinically indicated, and referral to other community services like continence team. We're just trying to scale back any extra added complications that might cause for our patient cohorts. So Kevin obviously is on the call. Medications is so important for us to think about how we review medications. And we've got a fantastic service within our PCN that's operating really effectively to review polypharmacy and help identify risky medications that can lead to falls and other adverse health outcomes. So these patients need this structured medication review, which is a personalised medication to really think about what affects the medication that person is on and the risks around that medication. And again, people that are doing these reviews have a really good sound understanding of national and local guidance and evidence-based practice. So we've got a really great resource that we can tap into here. So thinking about malnutrition, we absolutely know that weight loss increases risk of sarcopenia, and that comes with all sorts of different complications. So this is again really thinking for the care homes, really, why is my patient not eating? What barriers are there to eating? Are they on laxatives, or are they constipated? Are they feeling sick? What menu preference do they have? Does my patient need help? What assistance they might need with menus and feeding? Does their food look appetizing? And considering how the meal is served and often suitable complements, flavourings, And again, we know in terms of social space and using the dining room, it really encourages social eating, which can encourage us to actually have a better oral intake. So a lot of the homes, again, are doing this, thinking about how they increase calories and fluid intake. A lot of the homes are already using a fortified menus and meals, thinking about snacks and drinks throughout the day, trying nourishing fluids, again trying a varied of nutritional supplements. Again, this is obviously not just pertinent to the patients in care homes, obviously very pertinent to patients who are living at home as well. But we've got good resources in our service, so we can use community dietitians and speech and language therapy teams as required, so really tapping into those types of resources. And thinking about, again, for the care homes, how can they keep a track on things? So use of food and fluids balance charts, key, plus weekly weights. If they're worried about their patients, all of the care homes generally do a monthly weight. But again, if patients losing weight, they need to probably step that up, and they need to be doing that a bit more regularly to really try and ascertain what the pattern is. And to identify champions within nursing and residential settings, again, to promote the agenda around nutrition and hydration. Because even though we have this awareness, there is still significant problems with patients not getting good enough nutrition and hydration when they're being looked after 24 hours a day, which is unacceptable. So again, regular weights and use of sort of universal tools as well, that helps identify malnutrition. So that's really for the care homes. So the main thing around the 6 M's is really about what matters to me. So what matters to the person? And we need to ask those conversations. We need to have those conversations. We need to ask those questions. So if we can gather patient-centred goals and care plans through our universal contingency plans to really identify what are the issues for that person. So really it's about co-creating solutions. So working with patients and families to identify what's important to them, and how can we encourage independence rather than dependence on staff and carers. So I think lots of people go into care homes and nursing homes and there is this thing about things being done to them. But it's really about encouraging us to keep maintaining people's function and maintaining their independence to make decisions. And there are some great care homes that very much encourage that as part of their philosophies and their values. To educate families to participate in supporting older people to keep well, teaching exercise programs, again, getting families involved in long-term care planning, which again is really pertinent for the care homes. So Age UK have done a long list of sort of statements that people living with frailty often suggest as being crucial to them. And again, it's for us to ask those brave questions and say, how I'm supported to be independent, that I can do activities, and what are their priorities? What do they see as their sort of key things they want to focus on? We need to encourage people to make their own decisions, and with advice and support from families, friends and healthcare professionals. And I want to plan my own care for people to work together, to understand me, to understand what my needs are. And really that's the focus that we need to be taking with what matters to me, rather than us as healthcare professionals making all the decisions. The decisions really should be pushed back for the patient to be empowered to make them. And lastly, there is lots of fantastic resources on e-learning for health around frailty. And there's also frailty competencies as well. So I would encourage everyone to look at the different frailty tiered training, and depending obviously where you sit, really to think about the level that you would want. But Frailty 2A and 2B is for registered healthcare professionals, and Frailty Tier 1 is for unregistered healthcare professionals. But there's some fantastic resources online, and lots of really great training videos and exercises, and really just try and sort of contextualise frailty and bring it into your working practice. So that is the end of the presentation. I will try and stop sharing my slides so anyone can ask questions. Then, so any questions? Stop recording.